Hello, I'm David O'Malley from The Ohio State University and the James Comprehensive Cancer Center, and I'm honored to lead the GOG ovarian cancer portfolio for GOG Partners. Thank you for joining us once again for another episode of GOG GYN Live Series. I am thrilled today to have one of my good friends, Dr. Keta LaRussa, to discuss the new data presented at this year's ASCO as well as the SGO meeting. Keta?
Hi, thank you for inviting me. I'm very happy to be here.
Where are you practicing now, Keta? You gotta give your institution some love, right?
I am in Milan now. I'm working in Humanitas University.
So next meeting has to be in Milan, okay?
Yeah,
Fair?
I'm
All right.
waiting for you.
All right. Today we're going to look at the science, some of the data, and kind of real world implications here. Okay, so let's dive right in. Now, ROSELLA that you presented at SGO showed an overall survival benefit of 35% with over 4-month median. Now, I don't like median overall survival. I like the hazard ratio. I like to see those separation of curves. What does this mean? What's this benefit mean to our patients? What does this benefit mean clinically?
After several years that we did not have any option for platinum-resistant ovarian cancer, now we have regimen that increase overall survival. For several years, we were stuck with about 12 months median overall survival for this patient, but now with this new regimen, we have increased overall survival. And what you said, David, it's not the median, it's the shape of the curves that remain very well separated over time, suggesting a benefit even beyond the discontinuation of treatment.
What's really interesting is it almost has the curve that mirrors what we see in immune therapy.
Yeah.
I mean, those tails of the curve stay separate in platinum-resistant ovarian cancer. This is very exciting. Now, that kind of ties into this is our first FDA approved in oncology for the selective glucocorticoid receptor antagonist. I'm not a big mechanism of action dork. I keep it simple. Does it work? Doesn't work. However, this MOA is really interesting.
Yeah.
Well, tell us what the biologic rationale is for that. And I also want to know, why did we use nab-paclitaxel rather than paclitaxel?
Oh, yeah, this is very important because also in a normal condition, we have discovered that elevated level of corticosteroids activate the glucocorticoid receptor. When the glucocorticoid receptor is activated, it led to the transcription of anti-apoptotic genes and also genes that conditionate resistance to chemotherapy. And so it's very important to address this new mechanism of action. Why nab-paclitaxel? It's obvious that we are used to manage weekly paclitaxel in ovarian cancer. The data we have suggests that in terms of efficacy, nab-paclitaxel and weekly paclitaxel overlap, about 30-35% overall response rate, but nab-paclitaxel was instrumental in this combination because it does not require corticosteroids premedication. And it's obvious that if you have to intercept the mechanism and the receptor of glucocorticoids, you cannot use that.
So high cortisol patients do worse in cancer.
Yeah.
High glucocorticoid receptor expression on the cancer seems to do worse. So this mechanism of action makes sense. And we know that cortisol is immunosuppressant.
Yeah.
Right? So we're by blocking that, and we are then allowing for the body's own immune system. So again, immune modulatory, this is kind of screaming. Now, I think we're overcoming some of that inherent resistance to chemotherapy, though.
And David, coming back to what we were discussing a few minutes before, the shape of the curves, very well separated, suggesting that there is a change probably at the tumor microenvironment, and it is a benefit which is maintained over time because of that.
It's really interesting. We'll see as more data comes out about different combinations. Do we kind of see that persisting? Is this something that we would use in the future, even beyond them? I mean, those are questions that are yet to be answered. So speaking of questions, I think we need to talk a little bit more. So ROSELLA was no biomarker.
No.
Okay. So when we look at this, how are you looking to take this into your practice every day? We don't have a biomarker, we have MERV, which with a biomarker, we have B96 with PDL1. So this isn't a biomarker. How's that going to influence how you use it?
But we try to address if a different level of cortico or glucocorticoreceptor impact on the efficacy of relacorilant. We did it in the phase 2, and there is no correlation. So definitively, this is a no biomarker treatment. Biomarkers are an opportunity in terms of personalized treatment, but sometimes also a limitation, particularly when the biomarker is not reimbursed, as occurred in several countries, including mine. So the possibility to have a broader regimen that all patients can join and can obtain benefit is for sure an advantage.
Well, that's really interesting. I always forget about that from the European perspective. Actually, as the biomarker and availability of biomarkers is important, and has been challenging for some of our agents. Now, when I looked at the toxicity, when we talked about the toxicity, it seems to be driven by the nab-paclitaxel. How did the nab-paclitaxel versus nab-paclitaxel relacorilant, how do you feel that data looks? Is this all the nab-paclitaxel? How much is the relacorilant adding to potential toxicity?
So the most frequent toxicity that we have seen with this combination is anemia and fatigue, but most are related to the chemotherapy also, because it's important to underline that relacorilant is an oral drug that in this combination is given in an intermittent schedule. So it's not a continuative schedule, but intermittent, the day before, the day on, the day after chemotherapy. And when we look at the toxicity, according to the duration of treatment, because patients treated with relacorilant and nab-paclitaxel experience a longer duration of treatment, this difference in toxicity almost disappear. I can tell you that I had the privilege to do the trial, and so also to enroll several patients, and I can tell you it's a very well tolerated regimen. And nab-paclitaxel has another advantage: less neurotoxicity, which is a problem for patients that has already received paclitaxel, and less alopecia, which is important for our patients.
Well, I think it's something important that you said, which more of the relacorilant is not better. You actually showed this in the phase 2 that the intermittent dosing was better than the continuous.
Yeah.
So, if a patient's listening to this, we don't want her to say, I'm going to take it every day, because that actually didn't do. So this intermittent dosing has been important. Another example of the weekly 3 weeks on, 1 week off seems to be beneficial. So FDA approval, NCCN preferred listing. How is this going to reshape your clinical practice? And maybe we'll just take a few seconds to talk about the regulatory landscape. But how about in your clinical practice? How is this going to reshape platinum-resistant ovarian cancer in the next few years?
We will have, hopefully soon, also in Europe, the possibility to use a regimen which is very well tolerated for heavily pretreated population. I just want to remember that in this trial, 47% of patients have received 3 prior lines of therapy. 100% of them have received bevacizumab. 60% of them have received PARP inhibitor. This is the population that we treat now in our clinical practice. This is the patient I will meet tomorrow morning in my visiting room. So I'm sure that this regimen will represent a great opportunity for the patient. And we are updating our European guidelines. Hopefully, we will have very soon the drug also in Europe.
I hope so, for your patient's sake. We now have much better options for platinum-resistant ovarian cancer with overall survival advantage. And in the regulatory impact here, we're going to have to look at how we're designing clinical trials, because with the overall survival advantage, we have to account for the weekly taxane regimens. Thank you for joining me today. It's so great to always sit down and talk to you. Thank you for joining us today, taking time to learn about ROSELLA and the updates on overall survival. And Dr. LaRussa, thank you for your commitment to our patients and moving the science forward. Thank you so much.
Thank you so much.